I'm Professor Chul-Ho Sohn from South Korea, and I work at the Seoul National University Hospital Department of Radiology. First of all, I'm truly honored to have the opportunity to present at this distinguished meeting. Today, I would like to evaluate whether the CMRO₂ threshold method can be used to access the Infarct core. So this is the AH guidelines 2018, but now there's a little changes 2026. But CT perfusion is widely used to access the Infarct core and pulmonary tissue in patients with acute ischemic stroke. In particular, a late window patient, Infarct core volume is used as an exclusion criterion, and the CVF less than 30% threshold used in diffuse trial has been widely adopted to define the Infarct core. So I believe that using a CVF ratio to define the Infarct core was a sound decision. Absolute CVF values differ considerably among the software platform, whereas the 30% threshold appears to be physiologically reasonable. Did you see that? 30% looks like electric failure completely. That is a 12 or 50 milliliter per 100 gram minute. It maybe is 30%. Although CVF less than 30% threshold is still widely used and a standard threshold, others continue to use adapt to different parameters and different cutoff values. Another, G has their own CVF 10% threshold for core infarct, and the other Canon, they use a CVV threshold. Also, different softwares, there are different threshold used. We often encounter cases like this in which the actual Infarct core volume is the diffusion lesions, almost a 20 milliliters Infarct core lesion, but CVF 30% threshold rapid programs do not detect Infarct core lesion. But other software, CVV threshold, looks like their Infarct lesion volume is 8 milliliter. CVF 30% threshold, is it true or not? Actually, I'm worried that. So we compared to with the DWI, which is a practical imaging method for identifying function, and attempt to minimize the temporal changes by restricting the interval between two images studies to within 1 hour. So included 42 cases, and the median time between CTP and the DWI is 37 minutes. It is cases, DWI Infarct core lesion 218, plus CVF 30% is only 446. Too much difference. CVV is better. These are small Infarct lesions. Still, CVF 30% is small, underestimated Infarct core lesion. So we summarize data. CVF 30% is underestimated, and the ICC is more than CVV threshold is much better than ICC, and the mean bias is also smaller than this one, CVV values. So I'm worried about this CVF threshold. So if we had to use CT, so accessibility, could other perfusion parameters maybe applied instead? Would that possible? What about CMRO₂? In the graph, CVF is here. This is Infarct region. How about CMRO₂ OEF? Much similar, more easy to define the Infarct lesions. But problem is, how can I do that? Was not PET, and the other ML-based approaches for estimating CMRO₂ were extremely complex. So some guys all come out. And then surprisingly, they propose an approach based on DSMR perfusion, in which OF max was measured and subsequently used to estimating CMRO₂, like this. So I'm first saw this COV. What is a COV? CTH divided MTT. What is that? So therefore, I thought evidence to justify the use of CMRO₂ threshold analogous to the CVF threshold. Fortunately, many distinguished researchers had already provided valuable insight in the area. This is a French guy. So less than 40% CMRO₂ was closely associated with the histologic infraction volume up to 24 hours post-occlusion. So in other words, less than 23 of normal value CMRO₂ was highly correlated with hypodense areas observed in later CT. This is also French guy, is it right? So therefore, using the same method as in our previous study, we thought to compare Infarct core volume measurement derived from CVF and the CMRO₂ threshold using DWI as a reference standard. But to be honest, I do not have a high expectation at first because the initial version of CMRO₂ maps was not impressive. But we tried. So totally 76 cases enrolled, and then mean interval time CTP to DWI is 79 minutes. Is a result? Surprisingly, 23, do you remember CMRO₂ 23% is much correlated hypointensity? Do you see that? But 26 and 27% is much smallest bias. And then 26 is highest ICC compared to CVF 30%. This is a rapid programs, but CMRO₂ is looks like this one. So 26, 27 is highest ICC and the lowest biases. So this is representative cases. Large impact regions, all CMRO₂ is much closer to DWI impact lesion volumes compared to CVF 30%. This is small impact. Even small impact lesions, CVF 30%, nothing. Only CMRO₂ define these impact lesions. This is one real case. 4-year-old man, non-control CT. Where is the lesion? Radiologist maybe easily define this one. This one is a low density here, insular and frontal lobe, also here. So CTA, M2 is occlusion, but CVV threshold. This is Canon Toshiba. Now it's Canon, right? They use the CVV threshold. So core impact lesion is here. Volume is 6.5 millimeter. But rapid CVF doesn't find impact core lesion. Or 20, 38, also all nothing. But this is the initial version of CMRO₂. So image is not quite well, right? But lesion is here. Did you agree with that? But anyway, our procedures 26 threshold defined 50 millimeter is Infarct. The CMRO₂ is here, increase the CMRO₂ in that areas. This is a new version of CMN urocyte. There's a much improved imaging quality. There is a CMRO₂ is a decrease in here, and the OEF, CTH, COV. COV is a little decreased. That means infarct, right? Recently infarct. So very related that physiology. So CMN, CVF also defined as 4.5 millimeter, but rapid doesn't find that. But CMRO₂, 6.7 millimeter defined the infarct lesions. And real DWI, maybe 40 minutes later, DWI lesions here. So volume is at 26. So already radiologists know that CT hypointense region is here, left frontal lobe. Why CVF threshold, especially rapid, why do not detect? So I'm curious. So we reanalyze our previous published data, 26 cases, but unfortunately 6 cases are dropped. Totally 70 cases reanalyzed a new version of CMN. So this is our result. Still, CMR is a very similar ICC to rapid 30%, but bias is a little more the smallest bias is compared to CVF. So still, CVF 30% rapid programs underestimated. So 38 is much close to real impact reasons. So this is another interesting case. 87 years old man, initial NIH stroke is 19. The CT time is for 10 hours, 40 minutes after onset of symptom. MRI scan is just 22 minutes after CT scan. This is the aspect score. 3 is a large infarct core lesions. Did you see the low densities are here, temporal, right temporal? Insular dot sign is here, MC dense sign is here. Already low density, much low density is visualized as CT, non-con CT. The CT angio, MRO occlusions, but still another temporal branch is open. But this is GE. GE used CVF 10% threshold. That's why I don't know. So impact core lesion 50. They say CVF 10% threshold is more close to rapid 30% reasons. They published a white paper just inside papers. This white paper say 10% is close to CVF 30%. So they use it CVF 10%. This is a rapid 30% is 67 millimeter. This is a CMN 30% 73, very similar. But CMRO₂, 26 is 105 millimeter, a little much larger than CVF threshold. This is the imaging. So much improved that image quality. So whole right temporal area, the CVO is much decreased. But 22 minutes after CTP, the patient performed MRI. That's why something problem, right? Why do you use 2 images? It is not our routine protocol. Do you know Korean medical crisis? At that time, our residents all get out the hospital, so we have a lot of problems. So another urologist come to the ER. He know that our protocol. So perfusion, he use it. He's all the fashions. He uses CTP and MRP. So we got interesting cases. So DWI and another perfusion, just 7 minutes interval, DWI and the PWI. So this is the DWI regions, very close to CMRO₂, 26 regions. Infarct core lesions, DWI, 125. But CERCare, 97. I don't know which is True. I don't know really. But CMRO2 maps looks like this one. It's more close to CVF, CMN CVF threshold. This is a MR perfusion CMRO2 maps. This is looks like 26 is a 70. So just a little difference to CTP CMRO2 and MLP CMRO2, little difference. Also, imaging also very little changes. The CVO is a little changes. So he tried to recolonization and successfully recolonized, and the MRA is reopened. But this is a one-day flare images, very similar to DWI, not much increased. Here is another interesting study. They compared the diffusion and perfusion contemporaneously. So they they thought that the CVF threshold approach appealed to perform for Infarct prediction. All these threshold 32% was suggested to be somewhat more optimal. They suggest that the CVF threshold is working to predict the Infarct reason, but 32 threshold is much optimal. They suggested. So we try to same thinking the CMRO₂, how about CMRO₂, was it working or not? So we one of the 4 patients, ML perfusion and diffusion, we compare that. One of the 4 patients. But interestingly, did you see that? 3, this is JLK, is another Korean software program. This is rapid and the circuit. Did you see the Infarct volumes? Big, a little big difference. So I don't know what is the true. But anyway, the rapid is a reference. We use reference to the ADC, the ICT. Did you see that the CMRO₂ is, it looks like a little bigger than 26. The 30 or 5 is much more better to ICC or less smaller biases. But we use a standard, the circular standard ADC values. We use a standard, smaller 20 or 26 CMRO₂ with a high ICC. Did you see that? Detailed ICC? CMRO is much higher, 4.9 over 4.9. So I think that the CMRO₂ threshold is well working. There is another one case, 26-year-old woman, and I just looked at 28. The image is very poor, but very wrong past cases. So ICC is occlusion, left ICA is occlusion. This is a whole territory infarction, left ICA. So Infarct lesions, ADC, rapid program, 311 millimeter. But CMN is a 233. Also a little big changes. But CMRO₂ in the middle, 280. Is well working, I think that. So this is my conclusion. CT perfusion drive CMRO₂ is a promising parameter for estimating in the Infarct volumes in patients with acute ischemic stroke. So I propose the clinical use that the added CMRO₂ core is a second opinion to reduce a false large core or underestimating. Yeah, thank you.
Thank you very much for this impressive and very clear results. Are there questions from the audience? First, oh, there's a question there. I think there'll be a mic coming up.
Hi, I'm Suik Sen from University of South Carolina. So the question I had was, did you also look at the subcortical or lacunar strokes for CMRO₂ with diffusion weighted image MET?
Subcortical areas.
Whether you looked at
Cortical or lacunar stroke?
lacunar strokes as well, yeah.
Yeah, I'm not included that cases. So it's only large vessel occlusions. So I'm just curious that we are in stroke case, in our stroke is routinely we use a CT perfusion, but so included some cases lacunar lesions, but CTP doesn't, detect the small lacunar infections. So in that case, MR DWI is the best choice.
Other questions? Otherwise, I think we should thank you for this impressive talk. Thank you so much for sharing your results.